Assalamu alaikum to all of you. I'm talking about the total arterial revascularization versus conventional CABG, and mostly I'm talking about the stats. So conventional CABG is the CABG procedure, which are globally performed procedures in the coronary artery graft. Majority, the 95% of the global procedures are the conventional CABG. In the current era, the procurement of the vein graft is typically taken by the surgeon's assistant or the residents, junior residents, which may injure the vein endothelium by stretching or overinflating the vein, and that may problem with the longevity of the graft. Widely use of the endoscopic vein harvesting can be a problem for the patients and the longevity of the graft because of the available evidence has shown that the 1-year graft patency is lower than the open graft, maybe due to the inadvertent trauma to the vein endothelium or traction injury during the harvesting and endoscopically. And surgical experience of the operator is the most important factor in the endoscopic vein harvesting. Arterial revascularization has divided into two types. It's the multiple arterial grafting, in which you use the reduced use of saphenous vein graft and increased number of the arterial grafts. Total arterial revascularization has complete revascularization with the arterial graft and no use of saphenous vein grafts. We will discuss in detail all of these. So 95% of your global procedures are the conventional, in which you use the single lima to LAD and the vein grafts. And the arterial grafts are the multiple arterial grafts are majority used in the Australia. They have used, and they are 50% of the cases, and patients receive more than 2 arterial grafts. In the United States, 80% of CABG are the conventional, while it's a total arterial is 10% in South America, and in the Northeast America it is about 20%. No. It's not working. So total artery revascularization with the internal thoracic artery and the radial artery is associated with a greater long-term survival as compared to the use of single interthoracic artery and vein grafts. The optimal conduit choice and the configuration in achieving the total artery revascularization remains controversial. So this is where we have to start who will be performing the total artery revascularization. There are phases of the learning curve to establish the total artery revascularization. A surgeon who has gotten the favorable outcomes in the conventional CABG, he can proceed towards the radial artery because it is easier and it is less time required. And then he can proceed towards the inside tube bilateral internal thoracic artery. Once the multiple arterial grafting performed in the more than 50 cases, then he can go for sequential and composite grafting, and then obviously towards the non-touch technique of the aortic outflow CABG. Bilateral internal thoracic artery, it was first described by the Suzuki and colleagues in the treatment of diffuse coronary artery disease. The total arterial revascularization was the largest ART trial, was the largest multi-center unblinded randomized controlled trial, which has enrolled more than 3,000 patients who received the bilateral or single intermemory artery. And it has proven that BIMA was associated with improved survival. Despite of these compelling evidence and the guidelines, BIMA remains underutilized in the CABG worldwide. It is 4% in the United States, about 12% in Australia and Europe, and 34% in Japan. Japan is the most using country, but otherwise all other countries are very underutilized. maybe because of external wound infection, but skeletonized IMA has proven that external wound infection is less if you take bilateral internal thoracic artery in a skeletonized fashion. So this is the configuration of bilateral internal thoracic arteries. You can put an anterior to the aorta, you can put it behind the aorta and pulmonary artery in the transverse sinus, or you can use it as a free graft. Radial artery procedure was documented by a Carpentier and colleague, but was soon abandoned due to higher occlusion rates than the saphenous vein graft. The use of radial artery as a bypass was researched in 1992 by the Ascot et al. For the second most important coronary artery target with the severe stenosis. In 2021, AHA guidelines have recommended as a class 2A indication. So this is the radial artery, and always use the radial artery after Allen's test, or now they are recommending that the ultrasound of the radial artery should be performed before harvesting. So, clinical outcome have shown that the superior actual survival in patients who have grafted the radial artery versus RITA as a free graft and after the LITA. Radial artery is an excellent conduit. It can reach any coronary vessel on the heart, and it's not prone to kinking and quite forgiving in the left, a little long. Radial artery has a numerous technical advantages, including the reduced operation time, adaptable length, and reach any target and simple handling. Radial artery is extremely versatile, and conduit can be used as an aortic coronary graft, or as a Y graft, or as a T graft. So where we can put the radial artery? In the wall, we can put it a radial artery on the lateral wall, or we can put it on the inferior wall. But the degree of stenosis is more important. If the degree of stenosis is severe, then you can put a radial artery. If the degree of stenosis is moderate, then either go for ITA or saphenous vein graft. These are the graft failure rates. So graft failure were lower in the radial artery versus non-touch technique of saphenous vein graft and free right gastroepidural graft. So contraindication to the radial artery is the positive Allen's test that indicates the absent palmar arch, heavily calcified radial arteries typically seen in the insulin-dependent patients, end-stage renal failure who have arteriovenous fistula, patients with the Raynaud's phenomena, and manual laborer in the cold environments, because hand claudication has been observed after the radial artery harvesting. So techniques and the anastomosis of the arterial grafting as discussed by Dr. Solat. You can put it as a T graft, you can put it as a Y graft or I-shaped grafts. You can put an sequential grafting as a side-to-side anastomosis, end-to-side anastomosis, terminolateral anastomosis, and the diamond-shaped anastomosis. So the composite graft is a LITA is as an inflow artery. And you can put a free radial artery, you can put a radial artery or right internal memory artery. You can put a saphenous vein graft. All composed graft can be constructed between the LITA and the second conduit, either in the T or the Y fashion. But if you have to bypass a ramus intermedius, then you can put a T graft. If you are putting a graft to the OM1 or OM2, then you need a Y graft because you need a more length. And because it is very necessary to left atrial appendage is a landmark where you put these T graft or Y graft because it is intrapericardial and it will prevent you from kinking or any other things. Here you can see that's as a T graft below the left atrial appendage. Sequential anastomosis offers the flexibility and options when used for the composite anastomosis techniques. Harvesting of the leta from the subclavian artery all the way down. If you are planning a sequential graft with the leta, and you can anastomose the diagonal and the LAD simultaneously. You need a 0-degree angulation or parallel trajectories between the sternal table and the leta to avoid the undue kinking of the leta. Leta is used for the construction of the sequential graft and the diagonals, and sequential anastomosis performed first before the terminal anastomosis. So this is the sequential anastomosis which has been performed as on the diagonal. So supporting evidence of the REPCO trial was the only long-term angiographic randomized trial which has shown the radial artery patency to both free REMA and the saphenous vein graft. Safety of the radial artery harvest is high and functional outcomes of the hand are minimal. In addition to the controversial conventional Allen's test, using an ultrasound as a confirmatory test can be performed before taking the radial artery. So this is the radial artery is far better than the free radial graft, free REMA graft and saphenous vein. So this is also the available evidence has shown that the multiple arterial graft and total arterial graft has superior long-term survival as compared to the conventional graft. What are the barriers towards the total arterial revascularization despite of this much evidence? So major barriers are the perception of the increased technical difficulty, increased post-operative complications, longer operative time, absence of the large-scale prospective randomized trial, and lack of the financial incentive for the surgeon. So with this, I will end this presentation, and thank you very much.